COVID-19 and glaucoma. Yeah, this is a pretty enormous topic. And at Columbia, um, New York City has been dubbed the hotbed of COVID during the midst of the pandemic. And Columbia was hit really hard. So it was a very interesting kind of experience, very, very real. And we had a lot of big issues to deal with, as a lot of you have had to deal with. I want to break this lecture down in a couple different ways, and I'll share that with you. I have no financial disclosures. I loved this quote from Nathan Radcliffe, who is the editor of, forget what it's called, I something. He is at Cornell. COVID makes risk stratification challenging for important glaucoma checkups during this time. In other words, not to put too fine a point on it, the already difficult job of preventing blindness from glaucoma got even tougher. And boy, was that true. How many talks have we had over the years, and how much research, how many years of research is there about compliance in glaucoma, getting patients to take their drops, getting patients to come in for their visits. And then all of a sudden, we shut down our clinics, and glaucoma patients, for the most part, were not seen as urgent patients enough to warrant an in-person visit that might put the staff at risk, that might put the patients at risk. The glaucoma population also is an elderly population, so one that has more comorbidities to think about. And this job of getting patients into clinic and seeing them and taking care of them during this time has been enormously difficult, and that's not news to anybody. We're all aware of that. So here are the three things that I want to break down. Number one, how did teleophthalmology get started, and how can we use that for glaucoma patients during a time like this? Number two, what have we learned about testing and cleaning the instruments involved in terms of seeing our glaucoma patients? Our paradigm has kind of shifted. And number three, what are the glaucoma progression things we have to think about because of COVID? So this is a great shot, and I'll tell you why. First of all, I never actually did a televisit with a white coat on. That was strictly for optometry times. But that's Gus Demaraeus, who is either on the call or you'll see him at the next lecture, and that's me. Gus and I were called in the first week of March to think about starting telemedicine protocols. This was right after the first case was announced in New York. Nobody was wearing masks yet. We're in a conference room with Dr. Chaffee, Dr. Liebman, and talking about telemedicine and how we're going to get this started and what this should look like. And then 2 weeks later, everything shut down. Gus ended up being redeployed to the ICU, as you see him there. And I was round the clock doing telemedicine from 8 in the morning until 5 p.m. And then our residents and fellows were taking over different shifts after that. But this was our reality of what we were doing day in, day out during COVID to take care of all of our patients. So Columbia came out with a number of publications on how we rapidly deployed the use of teleophthalmology and how trying to help other centers who were kind of grappling also with how to shut down the clinics and take care of patients with a host of problems. And then that really helped create a kind of a sequence of events for practitioners to follow. So our timeline looked like this. In February 2020, fortuitously, we implemented EPIC. Columbia, New York Presbyterian spent an enormous amount of money and got EPIC. It was a project that we had been working on implementing for maybe 2 years before that, or a lot of meetings. And then all of a sudden, EPIC launched in February. And this is kind of how telemedicine was able to take place in our system, because we had this amazing technology within our EMR system. So March 1st, first case of COVID was in New York City. And the week of March 14th, we already started getting the emails. We have to go through our patients' schedules for the next like 3 months and mark urgency, we were going to be closing everything down. And our telemedicine protocol started ramping up. We had to learn about regulations. We had to learn about licensing. I probably have thousands of emails about telemedicine at this point. So this is what we came up with. We published it in the Optometry Times Journal. Suzanne Sherman and myself were the optometrists who were handling a lot of these calls. And then we came up with this kind of grid of how to triage these patients who were calling in, and we came up with urgent and emergent patients, ocular disease follow-up, and routine follow-up. So all the patients had to be called, and then patients were also calling with visual complaints. And this is how we structured it about whether to have a televisit with that patient, when they need to actually come into the office, and how quickly they needed to be seen and followed up with. If you read through this chart, and you're welcome to take a screenshot of it, this one actually is from our publication in Review of Optometry. This is a helpful tool, but you'll see that glaucoma patients are not really so helped by this chart. And that was our experience. A lot of glaucoma patients, follow-ups had to be canceled. And that was because they were not seen as being urgent. And the most that you could do is really encourage people to take their drops over the clinic, but just to have them come in and take an OCT, which at that point, we weren't really using that equipment anyway, they had to be canceled. Rabia Karani is one of our residents and presented this work at the AAO. She put together these slides really, really beautifully. This was the first 5 weeks of the kinds of patients that we saw. And you can see that the majority of them are older patients who were calling in with televisits. And that was the concern. That was the problem why we didn't want to bring them in. So this is a fantastic chart. You can see that most patients who called in called with some sort of redness, dryness, foreign body sensation. And then after that, there was a lot of eye pain. And then a good majority were eyelid issues. I can't even count the number of styes and Schlesians that we managed through telemedicine. But you really had to be able to fiddle out which patients were emergent and which ones had to come in. And this is what our patient complaints looked like. And then we compared that with what the diagnosis ended up being. There were very, very few patients who had life-threatening and sight-threatening emergencies. There were a couple ulcers that we managed telemedicine through telemedicine. That was okay, and then they eventually came in. But we were able to see. We actually were able to see the ulcer pretty well on the camera, and it was pretty clear that it was a peripheral ulcer through contact lens use and things like that. I think there was one retinal detachment in all of this. There was one subarachnoid hemorrhage in a child in all of this. But most patients who were calling in did not have serious diagnoses. And then you can see how they were followed up, and if they were followed up in clinic or with an in-person visit. Obviously, monocular vision loss, all those patients came in person. So where does glaucoma fit into all of this? You know, telemedicine is not anything that's new. This has been discussed at least at all the conferences I've been in, and I haven't been out too long. And I know there's a ton of research, and teleophthalmology, telemedicine is kind of a buzzword. But it's more been this like esoteric concept of something that we could potentially do one day when we have flying cars, you know, and then all of a sudden we're thrown into where you have to be able to implement telemedicine. And glaucoma fits into that really nicely. So there's 3 different considerations when you're dealing with telemedicine in glaucoma. The first is an asynchronous approach. The second is remote monitoring. And the third is real time. And an asynchronous approach, that's where you store and forward. That's where you have one site that has clinic information gathering. So a patient might come in, take a visual field. That field may be then sent over to an ophthalmologist at a different location or an optometrist and evaluated. And these are the kinds of things that trucks go out and they do vision screenings in underserved communities and things like that. And this has been dappled with before. Then there's remote monitoring. There's always new stuff coming out about this, IOP contact lenses. There's a new IOL that's being discussed that can measure IOP and send data to practitioners. And these are things that we're probably going to be seeing more of. But this is a different way of monitoring patients remotely. And then in real time. And that's what my role was in terms of this telemedicine, real-time, immediate access to the patient using some kind of software and speaking to the patient, analyzing what was going on, and making a diagnosis and a treatment plan based off of that, or having them come in for an appointment. So this is Dr. Lisa Hark is a PhD who came over from Wills Eye a few years ago to Columbia, and she had done this project with the Wills Eye Group, Philadelphia Telemedicine Glaucoma Detection Follow-Up Study. I encourage you to go back and read it. It's really extraordinary work. And she showed how you can go into underserved communities and kind of do exactly what I just described, of screening them and getting them the care that they need and following up with comprehensive eye exams. And then when she came to Columbia, she made a very similar kind of study called the Manhattan Vision Screening and Follow-Up Study in vulnerable populations. And she launched this before COVID, and we did the pilot before COVID, and then she kind of had to totally revamp and change things. And it's become a lot stronger and a lot more helpful and just really extraordinary work. But I want to share this image with you to kind of show, to make something like this work, a telemedicine approach that involves multiple facets and involves, that kind of asynchronous, where you have some people reading, some people doing the work, some people, behind the scenes getting HIPAA approval and all that stuff. It really takes a village to make one of these things work. So in this study situation, you have a screening team that goes out. They are all these flyers, they collect the patient data, they come in, the patients make appointments, they have to sign all the forms, and then they get their AR done, autorefraction, they get an IOP measurement, they get a fundus photo, different things, pressure measurement, that goes into a retina specialist, glaucoma specialist takes a look at those photos, decides who passes, who doesn't. People who pass or don't have readable image then get scheduled for an exam. And that's where I came in. I would see these patients and then determine whether the patients who came to see me needed to actually come in and have a real exam. Challenges that telemedicine brings. Number one, physician engagement. So you're talking about physicians. You have to, first of all, recruit the physicians who are going to be doing telemedicine. And then you have to figure out the reimbursement system. That was just a huge hurdle in terms of figuring out how to code, and then with licensing, whether we could code. And because we were in an emergency situation, a lot of these regulations were relaxed. And that was really, really wonderful for all practitioners practicing telemedicine, because that meant I could see our patients who were living in Florida at the time, or people who escaped New York, and we were able to legally see these patients. We were right in the beginning, we were allowed to use things like FaceTime and non-HIPAA approved software. If the software from the HIPAA-approved software had failed, there was leniencies in terms of that. Obviously, all those regulations are becoming stricter now and will come back full force. But and then there's limited technology for intraocular structures. That's really the limitation for ophthalmology. Even though teleophthalmology has been discussed in the past, it was more about taking pictures and doing OCTs and visual fields and pressure checks. But no one had really come up with a good way that you could see the eyeball inside the eye well enough to make a proper diagnosis using telemedicine. Food for thought. Is there a benefit of telemedicine regarding compliance? So anybody who practiced telemedicine, I'm sure will have the same experience, that for a lot of these patients that we spoke to on the phone, it was, and we spoke through video chat on our HIPAA compliant platform, it was a lot of speaking things out, reassurance, helping them get through this, as well as encouraging them to continue doing their normal routines. Dry eye patients, when people are going through crisis, that's when they kind of need a little hand holding. Remember that we can send drops through different platforms that can be mailed from the pharmacy, because people were afraid to go pick up their glaucoma drops. We were able to help them get them from the pharmacy and mail them, and mail a larger supply. And there was a lot of benefit, at least on our end, in terms of speaking with these patients. And I believe that may have helped some of them be more compliant than they would have. I would love to hear your thoughts after that. Testing and cleaning. So Dr. Fingerwood had mentioned that Dr. Jeffrey Liebman, who is the director of our glaucoma service and the vice chairman, he wrote right away, how to think about doing a clinical, how to change our paradigm of how we see these glaucoma patients, what our cleaning practices look like. And there are a number of issues that you have to think about as being an eye care professional. Number one, all of a sudden, eye care professionals were targeted as being higher risk, right? This is totally not like anything that we had before in our profession, where we are the high risk people. And why is it? Because you see dentist pictures, they're wearing masks, they're wearing gloves. You see other kinds of pictures of professionals, they're wearing masks or gloves at the very least. And in our world, it wasn't something that we did. We weren't wearing masks. We certainly weren't wearing masks, and we were not wearing gloves between patients. There's a lot of mucous membrane exposure. If you're doing a contact lens fitting, you are touching that patient's conjunctiva, and COVID was found to be in conjunctiva. So there was a consideration for that. How exposed we were really made us a very high risk. And then in the surgical considerations, and this is obviously dealing not with optometry, but within eye care profession, is patients who are referred for surgery, if they have a risk of aspirating and they may be COVID positive, or somebody else may be COVID positive, and all of a sudden you're dealing with that in the surgical setting where you're exposing the technicians, you're exposing the surgeons, you're exposing the instruments, you're exposing so many different things, then those all had to be taken into consideration. So what should our exam look like? All of a sudden, we had to decide how many patients per hour, even the patients who were urgent who had to come in. And then slowly when the clinics opened up. So we completely changed our paradigm. When a patient comes in, they try to get their test done before they come into the exam room. They're in the exam room, and that's where they stay. They are in that exam room. You no longer have patients coming out to dilate in the waiting room. You don't have patients going out and waiting for testing. You don't have patients. Our exams with patients became much shorter because, frankly, they became more efficient. And patients were not shuffled around. They were in one spot, so that when that patient left the room, you cleaned everything down, or you had somebody come in and clean everything down. And then the next patient would come in. It was completely clean environment that had limited people going in and out. And then we had the calling patients beforehand. So we would call, there was COVID regulations about when patients had to be tested to come in, or if, that was for surgery patients and things like that. Most of us have implemented having some sort of plastic shields and barriers, obviously meticulous cleaning. Now everybody here wears a mask, and we wear 2 masks. We wear an N95, we wear a surgical mask over that. And then other PPE. I know that in the beginning, when we were going in, we were wearing the full garb, the whole PPE wardrobe. When we had to see patients who had a conjunctivitis, who maybe had to be seen for other things. And now it's come down a little bit. A lot of us wear scrubs. Some of us don't wear scrubs, but we wear the masks. People wear face shields. It's relaxed a little bit in that sense because everyone's been vaccinated, and the level of PPE has come down somewhat, but the same things, that you still wear a mask, 2 masks, and you still wear gloves. And then outside of that, it's kind of at your own discretion, I guess. Sequence of events of the exam. So this was something also we had to think about, and everybody has to think about, in terms of when you check the pressure. Are you checking with a Goldman and cleaning that tip? Or are you using an eye care? For almost all of our patients, we use an eye care. We were using Tonopen, and then we found a lot of problems with Tonopen. And if it's a weird pressure, and certainly with the surgical glaucoma patients, most of those patients are now getting Goldman, because you have to know what their pressures are, even within a couple millimeters of mercury, and you can apply pressures. You have to be careful how you check with the other methods. So those are all considerations to think about. This was really interesting. Many of you probably use the product Avenova. Our rep, Stephen Pine, came to us, this was, a couple weeks ago, when he showed me this study. And I thought this was interesting. We don't use Avenova to clean our products, okay? We use the same old alcohol that we've always been using. But he showed me that Paul Finger had published using Avenova to get rid of COVID on different surfaces. A fascinating study. I can't speak to the how it was done. I didn't look that deeply into it, but just something to consider. This is where creativity comes into play, and things that we should all be thinking of. Visual field testing. This is probably the one that took the biggest toll in the beginning. We had to decide whether visual field was testing for all the patients that we used to do it on, and we stopped doing a lot of visual fields for sure in the beginning of this. And that was mostly because we didn't know how to clean it appropriately. How do you decide to do visual field? And OCT data was really kicking in terms of going with taking an OCT rather than doing a visual field. And this was really, all these things can be looked at as opportunities to evaluate the other things that we have to offer that are could be a little bit safer for patients in a setting like this. And so still with visual field testing, even though there are ways to clean it, as I'll show you in a minute, it's something to consider whether or not a visual field is necessary at that visit, or maybe wait until that patient has can come back at the next time if there's no urgency, or maybe have, wait till everyone's out in the clear and been vaccinated or something. There's different ways of pushing off the testing. This is something Dr. Fingerette had sent out a while back earlier on with in the COVID pandemic. And this laid out how exactly you should clean the Humphrey. And if you are not familiar with this, it was put out by Humphrey. They have a pamphlet on this. I suggest that you all go back and look at it. You can take a screenshot of this, and I have the next slide too. But you have to remember that the bowl is not, it's not like cleaning a desktop. It's a very delicate instrument. It has to be cleaned appropriately when you have to use it. And now we are using it pretty frequently, much more frequently than we were several months ago. So this is fascinating. These studies are just so awesome. And you'll see Dr. Fingeret's on this one too. But visual field artifacts and glaucoma with face mask use, like this is what optometrists are just awesome at, is that we have a pandemic, we have to be seeing these patients, and someone comes out and publishes a study like this, which is so relevant. And so we're trying to do the best we can. We're trying to see these patients and to determine whether or not they have progression and add medications or not. And here we go. Visual field artifacts were found by wearing face masks in the same pattern as glaucoma defects. So for whatever reason, you get arcuate defects from wearing a mask. Who knew? Necessity is the mother of invention. And there's a lot of things that are going to be happening now with telemedicine. One of these groups came out and said that drive-through intraocular pressure checks were an efficient way of seeing patients. This is obviously not realistic in a place like SUNY Optometry, or not realistic in a place like Columbia, a place like in New York City. People cannot just sit in a car right outside the clinic. We just don't have space for that. But in a place like University of Michigan, where this was done, they were able to have patients drive up and get their pressure checked just as a monitoring thing. They could stay in their cars and just check pressure like that. Just fascinating things that we could only have dreamed about just about a year ago. Medical and surgical patients, glaucoma progression. So there are really three reasons why glaucoma patients progress. Number one, there was a delay in surgical scheduling. The patients seen in the clinic are more, there are definitely more advanced patients. There's a lot of surgeries that go on, and these patients tend to be older, and they had to be delayed for a number of reasons. I remember early on, Dr. Chaffee had the chief of ethics talk about, who to see and who not to see. And it was a massive, massive discussion, really, really difficult conversations. You have monocular patients who really needed that glaucoma surgery. And let's say they had a family member who tested positive. And this was just in the beginning of when things were happening, and nobody really knew what to do. That's when we needed guidelines. We needed things to come out. The eye of the storm, vision problems, part of COVID-19's collateral damage. So this was a really nice highlight by Katja Ritterbusch, who talked about all the different things that happened because care was delayed for ophthalmology patients. And there's a specific highlight at glaucoma, that these patients are ones that we tend to see much more frequently. And for us, that means every month, every 3 months, every 6 months, and their care was very much delayed. This was a fantastic paper that came out of Michigan, weighing the risks and benefits for glaucoma patients during COVID, where this was Josh Steins and several others did a study looking at how they were triaging patients with glaucoma clinic appointments, how to decide who to come in and who not to come in. How do you tell a glaucoma patient who you've been seeing for 3 years or 20 years or 10 years, that you have to not miss your appointments and then tell them to not come in? How do you decide who really has to come in? And they made a risk stratification based on their glaucoma severity, progression risk, that came up with a certain number. They compared that to the number of high risk features for comorbidity and COVID-19. And really interesting that his study showed that a lot of glaucoma patients were pushed off care. And that obviously resulted in patients having changes in their glaucoma. Delay in surgery. So this was also, as I mentioned, urgent emergent cases only, aspirating concerns, weighing risks, ethical considerations, and COVID testing availability. So, all of those things, this was really the test of, I think, optometry within glaucoma. And this will be the test moving forward, because this is a disease that never before this pandemic happened would you have said, let's cancel all of our glaucoma patients for the next 3 months because it's not safe for them to come in. Where we were constantly saying, come in 3 months, come in 6 months. And certainly a conversation that we've had in our clinics is that, is it really necessary for glaucoma suspects to come in as frequently as they come in? What is the appropriate management for a glaucoma suspect, a low risk glaucoma suspect? Do you see them once a year? Do you see them every 6 months? Do you see, if they have pigment dispersion, do you see them sooner? If somebody has low, early glaucoma and it was caught and it's already being treated and their pressure is 10 every single visit, every 3 months for 3 years, is it necessary for them to come in? And this last year really put us to the test, because looking back at our data, and I hope that the optometry community will come together and put something out of our clinics and see what happened to the glaucoma patients that we followed during this time. And normally they came every 3 months, normally they came every 6 months, normally they came every year, and all of a sudden that changed. I would love to see that data of how all of us, how our patients progressed or didn't progress, because that can also help us shape our next clinical paradigm of how often these types of patients have to come in. And we can probably get some really good data on there. If anybody wants to collaborate, please do let me know. That would be a great study. Is there a causative relationship between COVID-19 and glaucoma? So when Marie asked me to talk about COVID and glaucoma, I wasn't familiar with any specific cause of COVID-19 and glaucoma. With eye care, we know that COVID can cause a conjunctivitis, but there's definitely stories, and there is some research showing that obviously COVID-19 patients in bad situations get treated with steroids, and we know what steroids do in glaucoma. So those types, there is a small number that has been reported that seem to have had elevated pressure and have maybe developed glaucoma or worsening glaucoma. There's not enough data on it. I'm sure that more will come out, but obviously when someone's on high doses of steroids, if that had to last for long periods of time, those patients that are a higher risk of either developing or progressing in their glaucoma. Are we back to normal? No. Right? We're not. Who knows what the new normal is? If this is the new normal, I hope it's not. I think that there were a lot of lessons learned from this in terms of dealing with glaucoma. I think that unfortunately, those studies that we will be able to do now and see what happened when we stopped having patients come back for follow-ups, when patients stopped feeling comfortable to going to get their medications, how many of those progressed. I think that data will come out. I hope it will, and we'll be able to see, moving forward what to do, and it will guide what our new normal looks like. But I hope that we are not completely back to normal, and obviously everybody who wrote this paper agrees with that too. Thank you so much for listening, and I would love to take any thoughts, questions.
Thank you. Thanks, Shira. So question is, can you get back to the visual field bowl cleaning, or just touch upon that a little more? Any other, I know, you got into it just saying you start, you have to really be careful. So, I mean, how do you go about, doing it now? Is it, any other?
Let me go back. What I do know is that in the beginning, we basically stopped doing visual fields. Okay, the visual field was really reserved for patients that felt needed it. And that was just very few and far between. Now we do it. Now I believe that the technicians follow this protocol of cleaning it. I don't clean it myself, so I can't really talk to that, but I do know that we follow the rules of how to clean it between patients. And obviously the imaging room doesn't have more than one person there at a time. There are all those regulations. I don't know if they're different between different cities, but in New York, regulations are pretty strict.
Yeah. No, I mean, I think you have it written. The key is that you have to kind of like spray the bowl let it dry and not scrub or wipe the bowl down, because as you said, it is very, very sensitive. Um, uh, you know, so there is a question, is there a handout for this lecture? Yes, Betsy will make that available. Did you say mask wearing while taking visual acuity test induces a scotoma? So really talking about visual field testing.
Yeah, so that was that study. Murray, I think you were on that study. Yeah, here, visual field artifacts. And the data that I saw when I was looking at it showed that you could get an arcuate visual field defect that mimicked glaucoma, a glaucomatous defect. So it could happen.
Yeah, there are a host of papers that have looked at this and shown that it can be kind of like a trial lens, a rim defect, or just diffuse loss if the glasses or the lens fogs. I mean, it can show up in a host of ways.
I'm going to make a comment, actually. Someone just posted, handheld slit lamps really help in non-contact patient care. So I use a handheld slit lamp only in that telemedicine study that I shared with you about the Manhattan Vision screening. It's tough. I haven't used it since COVID, but the person who commented about that, do you use a barrier with that? Because that makes me a little nervous, actually, to get very close to patients, even with the masks, without having those plastic shields and barriers that the slit lamps have. I don't know if you want to comment on that, but I would be a little nervous about that.
That's a good point. I don't have any experience with that, but so yeah, why don't we just, Shira, that was a great job. What a great talk on COVID, and really it's it's going to be an evolving topic that is not going away. The person wrote no barrier, double mask.
I don't think that would. I don't know what they're doing about that with us. I know that obviously the pediatric community has to use a slit lamp sometimes, handheld, but I don't think anybody would say to use that instead of the main one with the barrier. Although I'm not sure which patients you're referring to.
Yeah. No, I'm not sure. So, Shira, thank you.